Welcome to SkinSync, the official podcast of Elevate-Derm Alliance, your trusted source for the latest in dermatology for PAs and NPs. Join our hosts for real clinician perspectives and expert guest insights as they explore everyday dermatology topics with practical takeaways.
Hello and welcome to the next episode of the SkinSync podcast. My name is Shannon Moranti. I'm a dermatology PA from Naples, Florida.
And my name is Buccinita. I'm a dermatology PA from the Atlanta, Georgia area. And before we get started, Shanna, I wanted to invite all of our listeners to the upcoming Elevate-Derm conference in Tampa, Florida. You can catch us for live SkinSync episodes, and this will be held November 12th through the 16th. Registration is still open. We'd love to have you guys there.
I love those live episodes. They have been so much fun to record on stage. So I cannot wait to record some more of those with a live audience with you, Bucci. That's going to be great. So tonight, let's go into our next discussion on something that we are both very passionate about, dermatology conditions in skin of color. Bucci, it has been postulated by 2045, greater than 50% of the U.S. population will be people of color. So we as dermatology PAs and NPs and docs and nurses and anyone else listening to this podcast, we need to evolve. We need to learn. I don't know about you, but when I trained 25 years ago, we trained on dermatology textbooks. Yes, old school textbooks where you actually had to flip pages, but they were textbooks with pictures of old white guys. So I had a very non-diverse training and really had to learn a lot about skin of color on the fly and through conferences and through really, truly kind of taking a self-deep dive into learning about what different skin conditions look like in different skin tones.
So Shanna, you're absolutely right. And this topic is really something that's always been near and dear to me. I have a pretty large skin of color population as far as my patients are concerned, and it's really important that we have this conversation. And you're right, when it comes to textbooks and literature and training and research, it's really not a diverse population that we're seeing. Oftentimes we're seeing conditions in the same skin tone. We're missing the darker skin tones, and unfortunately it makes it harder for us as clinicians to be able to recognize and diagnose these conditions appropriately. I was blessed enough to train in a very diverse area in Miami, Florida, and I had wonderful supervising physicians and the PAs, and I was trained really well, but unfortunately I still didn't get the adequate training. So over the years of my career, I've really put in a lot of effort to make sure that I'm seeing and diagnosing these patients appropriately.
I love that. I'm sure patients seek you out specifically in your area, even though, in your specific little pocket of Atlanta, it's not very diverse. I'm sure people come to find you because the patients trust you, because they believe that you understand their skin condition. You understand what they're going through. You understand that maybe, their skin condition has been overlooked. And I want patients to feel that way no matter what color APP they see, no matter what sex of the APP they see. I want us all to be colorblind, and I want us all to be able to truly treat patients and treat the actual condition. But it's very difficult for the newer APPs that have maybe not seen a lot of different diseases in different skin tones, because let's be honest, red does not always look red.
No, you're absolutely right. I think a lot of my patients really do seek out a provider of color because perhaps they have seen people that were not the same complexion. And oftentimes they feel like they were really not treated adequately, or maybe their condition wasn't fully understood. Maybe there was some miscommunication happening, particularly when it comes to hair disorders, which we'll talk about shortly. So I think it's really important, again, that all of us get really comfortable seeing, diagnosing, and being able to have that conversation with our patients who are or from diverse backgrounds. So let's kind of dig in a little bit. Go ahead.
And if you are, a very fair-skinned white girl like I am, I specifically choose medical assistants that, speak Spanish and have, a beautiful, richer skin tone so that, the environment in which the patient is being seen feels more inclusive, and actually, patients feel like they can share more. I oftentimes will have patients, like, as I'm teaching and training and talking to them, they'll look at my gorgeous Black 20-something medical assistant for confirmation. It's so validating, and I've actually pointed it out to her, and I've given her, such, amazing, accolades, because I said, "They're looking to you to give the validation that, yeah, this white blonde girl actually knows what she's talking about."
That
So
is
if
so
you do
great.
find yourself in a situation where, maybe you are not, being, maybe you feel like you don't have enough knowledge, or maybe you don't feel like you have the right to talk about it. You absolutely do. We are all knowledgeable about skin tones, but make sure that you make your exam room very inclusive and very comfortable for patients of all skin tones.
I love that advice, Shan. I think it's so important. And I've mentioned this in previous talks where patients really do that. They are looking to your MAs and the office staff to say, like, does she know how to treat my skin type? Should I really follow this therapy? Like, so they really are asking these questions. So I love that idea. Diversifying your office, kind of bringing in unique skin tones and languages. It's a wonderful idea. So let's dive into some of the common conditions that we're seeing in dermatology, particularly in skin of color patients, and the impact they have. So, what's one that you typically see a lot of?
So, one of, I think, the most impactful and the most common things that we see, oftentimes because maybe it's the earliest thing that they are seeking out medical advice for, will be acne. And of course, acne affects everyone. Acne is blind to skin tone. It affects all races, all sexes. It affects everyone. But patients with deeper, richer skin tones are often much more bothered by the hyperpigmentation or the post-inflammatory hyperpigmentation. And we know that inflammation is present throughout the course of acne, but in different skin tones, inflammation can look very different and can kind of stain the skin in very different ways. So I often see my acne patients coming in asking for help with the dark marks that are left behind from their acne lesions. So this often leads them and drives them into our offices where they're really begging for our help.
Yeah, absolutely. And so I think it's really important for everyone listening to recognize that for many of your patients with darker skin tones, the post inflammatory pigmentation is equally as important as treating the acne, sometimes more important for that patient. And if it's really not addressed adequately during that first visit, you may lose their trust. You might lose that confidence. But it's really important that you address this. I know as someone who does get the occasional breakout in spite of my wonderful skincare regimen, my concern when I have a pimple is actually not the lesion itself. It's the pigmentation that I know I'm going to have for weeks or even months after the fact. And that's usually one lesion. And that's enough to really just, kind of disrupt my day. And I have to think about what makeup to use or concealer. It really is frustrating. And so just imagine somebody who has a face full or a chest or back full of acne and PIH. It really is something that impacts them, what they can wear, their confidence. So I really want you to recognize the importance of treating that pigmentation, or at least addressing it early on.
And address it from the get go. Let them know that you're aware of it, that we are going after it, and that whatever regimen you are setting up for that patient, choose regimens that are actually, that have been proven in deeper, richer skin tones, that have done studies on skin of color. Make sure that you address it right off the bat so that you know it's not secondary in the provider mind. It is right in the forefront, just as it is in the patient's mind.
Absolutely. I think one of the things we should also keep in mind too is obviously outside of the PIH, we do see more keloids and more hypertrophic scarring in this patient population. So addressing that acne a bit more aggressively is important. And just one thing that was unfortunate to learn is that when we're dealing with patients of color, Black and Hispanic patients, they're less likely to be offered systemic therapies for their acne. And so I really want everyone to kind of keep that in mind, recognize that maybe you might be the first provider that's mentioning isotretinoin. You might be the first that's offering spironolactone or an antibiotic. And so make sure that you're treating this acne early, aggressively. I would honestly really look at the PAH almost as significant as scarring. While it is not permanent, it's still just as emotionally and cosmetically distressing. So make sure that we're addressing that, offer these systemic therapies. I think it's important that we keep it in mind.
And that's heartbreaking to hear that providers will address a certain, percentage of the population with less options for systemic therapy. As a matter of fact, if we see scarring, we should be more aggressive about, treating systemically. So we need to address that right up front and let our patients know it is, of paramount importance, and we are going to get to the bottom of it and really shut it down before it creates more permanent damage.
Absolutely. So let's dive into another common condition, psoriasis. So again, this kind of impacts every patient population. And with skin of color, it definitely has very different presentations that it's really important to recognize because this may delay that diagnosis, delay their treatment, and increase, of course, the post-inflammatory pigmentation. So what are some of the clues that you're looking for in diagnosing a patient with psoriasis who has a darker skin tone?
I am a very textural person. I am a very touchy-feely, provider. Not in a bad way, but I would definitely want to make sure I feel those plaques. I want to see if I'm feeling that lichenification, the thickening of the scaling of those plaques. I want to see if they have a more violaceous skin tone. Again, you won't always see erythema. Sometimes it's going to look purple or dusky or just a deeper tone of brown. So you need to really look for those little nuances and then make sure we're also asking about systemic implications as well. Ask about joint pain, ask about cardiovascular disease, ask about other comorbidities that they may have that may be impacted by the systemic inflammation of psoriasis.
Absolutely. And a couple other things to keep in mind is, again, unfortunately, Black patients are less likely to be offered systemic therapies for their psoriasis. So just, really something you want to make sure that for every psoriasis patient that we're treating early and aggressively. The scalp is actually a more common presentation in Black patients, oftentimes with really thick plaques. And I found this quite a bit, and I'm sure maybe you've seen this too in my Asian population. Oftentimes their psoriasis can look almost eczematous, where it's this kind of psoriasiform dermatitis, and you're not really sure what you're dealing with. And you may have to kind of go through a couple systemic therapies to be able to get that diagnosis accurate because the biopsy is not always helpful. So just kind of be aware of these unusual presentations in these patients.
And I think as knowledgeable as we are getting about different inflammatory cytokines, remember the biopsy doesn't tell us exactly what
Right.
cytokine is elevated. So it does not lead us to, oh, this is a very, type 1 inflammation with IL-17. You need to use this biologic. We sometimes do have a little bit of trial and error there. So make sure that you advise your patients that you are working through and you're already thinking about next steps, and make sure that, again, you are looking for therapies that have been studied in these patient populations so that you know what to expect.
I love that there's many of the pharmaceutical companies now that are actually doing studies just for patients with skin of color. I think it's amazing. It's wonderful seeing those photos. It's wonderful seeing advertisements with this patient population. So I think it's important that we continue to see that with these clinical trials. And another thing to keep in mind is, again, although we know that BSA is really important when it comes to treating psoriasis. But even in smaller BSAs, if you're dealing with a patient who has just scalp psoriasis, remember that, especially for Black women, that this is huge, right? We're not washing our hair every day or every other day or even once a week in some cases. So asking a patient of color with textured hair to put topical therapies on their hair every day is just not realistic. So sometimes that means you do have to approach that conversation about oral agents or biologics much sooner than you would maybe another patient. So please keep that in mind. Offer these therapies early and often.
That is such a great clinical pearl. And remember, if you don't have a very diverse skin population, make sure that you are seeking out your own education online. There are so many amazing resources like Visual DX programs that you can actually download as apps or just go online and look at photos of different diseases in different skin tones. I feel like a skin condition that's gotten a lot of love, thank goodness, in the last couple of years. And they actually have done such a phenomenal job recruiting patients that are skin of color has been for our atopic dermatitis patients in AD trials. We have seen such a huge successful launch of some of the non-steroidal therapies and also, of course, biologics. And it is to a much needed audience. So many of our patients are itchy and miserable, and the inflammation and erythema is often kind of muted or not noticed in patients with deeper, richer skin tones. So make sure that you are taking visual clues and also those palpable clues if you do see patients that do have hypopigmentation, hyperpigmentation, more violaceous skin tones in your AD population. Make sure that we're taking notes to the variety of different ways that atopic dermatitis can appear in our patients with skin of color. Luckily, we have a lot of options nowadays. We've already done a couple of podcast episodes on these wonderful options. So please go back to your listening apps and listen to those previous episodes that we have already recorded, Bucci. But you and I are both really passionate about treating AD patients.
I actually love treating AD. I've always loved it, but I especially love it now. And particularly with skin of color, some things that everyone needs to keep in mind is, again, those different variations, those different phenotypes. So patients oftentimes are having more lichenification. We're seeing more papular variants. We're seeing more follicular accentuation, especially in my pediatric population. I'll find that sometimes they may not have actively itchy or inflamed, plaques, but they're just their follicles are just kind of more prominent, more accentuated. So remember that these different presentations, and remember that with patients of color, particularly Black patients, atopic dermatitis oftentimes tends to be much worse and much itchier because they do have higher rates of transepidermal water loss. They do have lower rates of ceramides in the skin, and so this does tend to present with itchier, more inflamed, severe atopic presentations. And again, that lack of erythema oftentimes leads to delayed diagnosis, undertreatment, and just misery. These patients are really having a hard time. So I think it's important that we diagnose early, treat early, and we have so many great therapies on the market now.
For sure. There's so many pitfalls when we don't recognize those early signs. We need to get patients under really good control. And luckily, we have a lot of wonderful therapies, both systemically, our biologic therapies, and the topical non-steroidals that we have for our AD patients. Let's talk about hair loss and
Oh,
scarring
yeah.
alopecias. I know you're very passionate about that. So tell me a little bit about that in our skin of color patients.
So much. We can talk about this for the next 3 hours, but so much to talk about. So,
This is
couple
only a
things.
10-minute appointment, Vicky. This is only a 10-minute appointment.
Right. Oh, no, my visits are never 10 minutes. They are easily 20 to
Never.
30 minutes every time,
Always.
sadly. So hair loss. Now, this is something where I think the biggest thing we need to keep in mind are a few things. Number one is scarring, alopecia in our patient women with skin of color. It is rampant, it is prominent, it is severe, and if we are not diagnosing and catching these things early, we're losing follicles. So these follicles are at risk if we're not diagnosing and treating early enough. Biopsy if you need to. I was listening to a webinar recently, and they mentioned that particularly for Black women, we're missing it. We're really missing these diagnoses a lot of the times. We're going clinical, and oftentimes we're not doing these biopsies to get the diagnosis early. So please make sure that you're evaluating these patients. If there's even a hint of hair loss, do an investigation, do a biopsy, find out what's going on early.
I
We
hate
want
to hear that. I hate to hear that we are missing the boat on those early diagnosis and that we may be able to intervene and prevent permanent scarring. That breaks my heart. What can we do better? What should we do?
So number one is really doing a proper evaluation of history, making sure that you are doing those little punch biopsies. It doesn't take much. 4 millimeter punch biopsy, find an area where there's involved scalp but still active hair follicles. And again, try to get to that diagnosis. Another really important key piece when it comes to alopecia, particularly in women with textured hair, is you can have multiple diagnoses at one time, right? So
Yes.
we know that androgenetic alopecia is common in most women as we get older, but you can also have that along with CCCA, along with traction alopecia. I had a patient today, she had 4 different hair conditions going on at the same time.
Oh
And
my goodness.
so if you're not addressing all of them, you're going to be missing the mark, right? You might be able to get the CCCA under control, but if you're not treating that AGA, then we're really not going to get that full success. So remember that these patients really do need need guidance and you need to make sure that you're getting all the diagnoses. You want to make sure that when you're dealing with traction alopecia, that it's truly traction alopecia. We know that FFA is becoming much more common, especially middle-aged women. We
It
know
is.
that you could still see other forms of hair loss that cause frontal, thinning. Please make sure that you know what you're dealing with when we're diagnosing traction alopecia. So I can go on. I can go on and on.
I love that. So I could pick your brain on this for, oh my gosh, hours and hours. And like you said, we could talk about this forever, but we'll try to keep it short and sweet. I think for the newer APPs out there, if you don't know what you're looking at, take a biopsy. Like Bucci said, get a 4-0 punch biopsy and get in there. And you might have to take a couple of different scout biopsies of the scalp to catch different nuances of the inflammatory cycle. You may have to take biopsies from different regions of the scalp, but try to be understanding of their hairstyle and don't take a biopsy right in the front where they're going to see that scar and hate you forever. Try to hide it, try to find an area of involvement that's not clearly visible if somebody's like looking straight at the face. So what do you do with counseling? Like that first visit? Because I think it's so important. September is Alopecia Awareness Month. I think we all need to be aware that we need to give our patients hope, and they need to leave that visit with even the littlest glimmer of hope that we are starting them on the path to success. So what do you let them leave with that first appointment, that first day? What counseling do you give them?
So I think the most important thing really is number one, leaving them with a diagnosis, right? Oftentimes they'll come to see us, they've been diagnosed with alopecia or hair loss, but there's not a specific diagnosis that they've been given. So that's the number one most important thing. Number two is if it is something that is chronic, let them know that, right? Help them understand if we don't keep this under control, you're at risk of losing more hair. Patients oftentimes they'll, get lost to follow up. They'll show up maybe 5 years later and they've lost so much more hair, and it really shouldn't have happened that way. So I think recognizing that these diseases are chronic and need therapies long term. I think it's important to be very sensitive to hairstyling. I had a patient today, new to me, wanted to be evaluated for hair loss, and she had a wig on. And this wig was glued down to keep it intact, to keep it from falling off. And she couldn't remove it during our visit. And I told her, well, we've got to bring you back to go ahead and evaluate it, maybe do a biopsy. And she was in tears. She was in tears. I'm so embarrassed about my hair. I don't feel comfortable coming back to see you without my wig on. And so remember that it impacts patients' confidence. They oftentimes have been wearing these wigs or extensions for years. So asking them to do without it is really a big ask. So be sensitive to hairstyling, recognize how impactful it is, especially for Black women, and, really just try to be understanding of that.
For sure, for sure. We all need to just take a second, even if we are running 30 to 40 minutes behind, and we know this visit is
Every day.
going to be far longer than we intended it to be. Take a moment to put yourself in that patient's shoes and treat that person like you would want to be treated. So this is, such an important, subject, and I really think that we can do another entire podcast on this. But let's talk about, how clinicians can get better. Like, how can we train our eye, make our patients of any skin type, of any ethnicity, feel comfortable, feel that we are confident in treating their skincare? What would you want me to say to you if you came to see me as a patient?
So I think really for most clinicians, you have to seek the information out, read the textbooks, find the resources. We mentioned Visual DX earlier. There's not a day in my clinic where I don't use that website to either print patient handouts or look at patient photos or understand different patterns in skin of color. So really do the work and, learn the information, go to conferences, read the text. You'll find it, but you do have to work a little harder to find that information. Also make sure that as listeners who are speakers or who are, educators, make sure that you're including skin of color photos in your presentations. I think it's really helpful for your audience to see this live at a conference or during a lecture.
Well, luckily, there are so many resources now for dermatology providers. Make sure that you feel comfortable treating just about anybody that walks in the door. I think if you are comfortable, your patients will be more comfortable, and your patients will have better outcomes for it. As we've discussed, previously, like the bedside manner matters, and you need to take a moment to be empathetic, be understanding, and truly like take their skin condition to heart and treat aggressively if necessary to get inflammation under control. And don't hide behind the naivete that, oh, I haven't seen this yet. Well, shame on you. Let's all learn more. Let's all be better. Let's all be better providers for all patients.
Great tips. I love that.
Okay. Well, on that note, we will end today's episode with just a sweet reminder to hopefully join us in Tampa, Florida for the live recordings of the SkinSync podcast that will be happening live this fall. We hope that you can join us. My name is Shannon Marianti. Abuchi and I wish you a wonderful Alopecia Awareness Month. Please go out there and treat those patients with empathy and with a big, huge heart. Bucci, thank you so much for all your input today. I always learn from you, and I so appreciate all of your knowledge. Yeah.
Thanks to everyone for listening.
Thanks for tuning in to SkinSync. Don't forget to subscribe to SkinSync on Spotify or Apple Podcasts so you never miss an episode. To explore more of Elevate's educational and career resources, visit elevate-derm.com. Please note, this podcast is for informational purposes only and not a substitute for professional medical advice. Always consult a licensed healthcare provider before making medical decisions. Clinicians must rely on their own judgment and training in all patient care situations.